Welcome to the Explainer. Today, we're going to jump right into one of the most vital clinical skills you'll need on the wards, the peripheral vascular exam. This is all about building a systematic, confident approach you can rely on every single time. Let's get to it.
So here's how we're going to break it down. We'll start with what you can see, then move to what you can feel, and wrap up with a special test that really confirm your suspicions. The goal here is to give you a solid mental checklist that becomes second nature.
All right, first things first. When you walk into a room with a patient with severe PVD, the most dramatic thing you might see is gangrene. But hold on, not all gangrene is created equal. Your number one job right off the bat is to figure out which type you're dealing with, because they tell two completely different stories.
And just look at the difference. It's like a tale of two tissues. Dry gangrene, on the left, is this slow, insidious process where blood supply just gradually gets cut off. The tissue literally dries out and becomes mummified. But wet gangrene? Whoa, that's a whole different beast. It's a surgical emergency, often involving a sudden blockage plus a nasty infection that causes everything to get swollen and just decay.
Now, this line of demarcation is an absolutely critical sign to spot. You can think of it as the body's own firewall. It's the battle line drawn between the dead tissue and the living, healthy tissue. And right on that border, you'll often see a little bit of redness or swelling. That's the body's inflammatory response at work, trying to contain the damage.
Okay, so once we've assessed for gangrene, it's time to zoom out. We're going to become clinical detectives now, looking for all the other subtle chronic clues that paint a picture of long-term poor circulation.
So what are these subtle signs? What are we really looking for? Well, we're looking for something called trophic changes. That's just a fancy term for the damage that happens when tissues are starved of oxygen and nutrients for a long, long time. And here's the absolute golden rule, something you can never forget. Always, always compare the affected limb to the healthy one. That's your control group right there in front of you.
First up, just look at the skin itself. It gets this very characteristic look. It becomes thin, pale, and has this sort of shiny, almost translucent quality. That's because the fatty layer underneath has started to waste away.
Next, look for hair, or more accurately, the lack of it. Think about it. Growing hair takes energy. It takes a good blood supply. When that blood supply starts to fail, hair growth is one of the first things to go, especially on the lower leg and the top of the foot.
And don't forget the toenails. You've got to look down there. Chronic ischemia makes them brittle and thick. And you might spot these transverse ridges. It's actually pretty cool. They're like the growth rings you see on a tree stump, where each ridge marks a time when the circulation was so bad that the nail just couldn't grow properly.
Okay, to round out our inspection, there are a few other clues to hunt for. You've got to check for muscle wasting. And don't just eyeball it, get a measuring tape out to be sure. Look for ischemic ulcers, especially on the very tips of the toes. And of course, always look for scars from previous surgeries. They tell a huge part of the patient's story.
All right, inspection is done. You've used your eyes. Now, it's time to use your hands. We're moving on to palpation, and this is where we're going to feel for temperature, check for any tenderness, and hunt for those all-important pulses.
You need a system here. Do it this way every single time, and you won't miss anything. And that temperature check, it's not just a casual thing. You need to note the exact level where the limb goes from being warm to cool. That single piece of information is critical for a surgeon who might be planning an amputation.
Okay, let's talk pulses. These are the big four in the lower limb, your bread and butter. Your job is to systematically track them down. And remember, while finding a pulse is great, not finding a pulse is also incredibly valuable information. It helps you pinpoint where the blockage might be.
Ah yes, the popliteal pulse, the bane of every medical student's existence, right? It's buried so deep in the back of the knee, it can feel impossible to find. So what do? You're there, pressing away, and you feel nothing. Do you just write it off as absent? Well, here's a fantastic little clinical pearl called Busch's test. This is one of those things that will make you look like an absolute pro on the wards. You have the patient cross their leg and you just watch their foot. If you see it gently bouncing in time with their heartbeat, boom, that's a positive sign. You've got a good popliteal pulse, even if you couldn't feel it. Right, so we've looked, we've felt, we've gathered our clues. Now it's time for the advanced maneuvers, the special tests that help us confirm what we think is going on, and crucially, to figure out just how severe it is. First up is Buerger's angle, and this is a total game changer because it's not just a yes or no test. It gives you a number. It actually quantifies the ischemia, and that cutoff, less than 30 degrees, is a major red flag. It tells you you're dealing with severe critical limb ischemia. So how do we do it? It's this beautiful two-step process. First, you lift the leg up. Why does it go pale in a sick limb? Simple physics, really. The arterial pressure just isn't strong enough to fight gravity. Then you have them hang the leg down and this crazy thing happens. The foot turns this deep purplish red color. That's called dependent rubor. A healthy leg won't do either of those things. It's an elegant test.
Now, let's switch gears to the upper limb for a second and talk about Allen's test. Why do we care so much about this one? Well, because it's a safety check, a really, really important one. You have to do this before you ever consider a procedure like putting in an arterial line or drawing an APG to make sure the hand has a backup blood supply.
Whew. Okay, that was a whirlwind tour, wasn't it? We went all the way from looking at the skin to feeling for deep pulses and doing these special tests. Let's pull it all together into one final, neat package to really lock it in. And here it is, your whole exam on one slide. This is your workflow, your cheat sheet. You inspect, you palpate, you auscultate. Yep, don't forget to put your stethoscope over arteries like the femoral to listen for bruits, and then you finish with your special tests. Practice this sequence until it becomes pure muscle memory.
And that's really what this is all about, isn't it? This isn't just an academic exercise to pass an exam. Every single sign you find, every pulse you can or can't feel, it's a critical piece of the puzzle. It tells you what scans to order, how urgently you need a vascular consult, and how to manage the patient. Mastering this isn't just about being a good student, it's about directly impacting your patient's outcome. Thanks for joining me on this one.